We're going to continue with alterations in body system. And we'll pick up from where we left, and we'll be looking at appendicitis. Again, just like I've always mentioned, you always want to break down words on the NCLEX, and that will give you an idea of what the disease process is about. So when I see itis, that tells me inflammation. Appendix, so I know that it's an inflammation of the appendix. So this is a condition in which the appendix becomes inflamed, and then it gets filled with pus. The patient is in pain, and it begins with pain near the belly button. And this pain will move from the belly button to the right side, which we refer to as McBurney's point. Okay, so that's McBurney's point there. So we said you're going to have this peri-umbilical abdominal pain that shifts to the right lower quadrant, which is our McBurney's point. And again, it's often accompanied by the clients would have complaints of nausea, vomiting, they would have poor appetite, and they will have that localized tenderness and muscle guarding. They would also present with low-grade fever. So again, you have that peri-umbilical pain that shifts to the right lower quadrant at the McBurney's point. Again, you would see the client presenting with anorexia, those GIT symptoms, nausea, vomiting, and you will see muscle guarding, like they try their stomach, the abdomen could become stiff. And then you will see low-grade fever. And most times where you have fever, you would always see an increased white blood cell counts. Again, what's our normal WBC count? It should be between 4,500 to 11,000. What's our plan in managing these patients? So again, we want to make sure we are not using any heating pads because it can cause the appendix to rupture. So no heating pads, no enemas, no laxatives, because either of these can cause the appendix to rupture. We also want to maintain nil per oral status, at least until the blood lab results have been received. We want to give IV fluids to prevent dehydration in our client. And again, we don't want to give analgesics yet until the cause of the pain has been determined. We can apply ice bags to the abdomen to help to alleviate pain. Because remember, if you apply heat to the abdomen when we are suspecting appendicitis, it will actually help to increase circulation, which in turn can cause the appendix to rupture. So that's why we don't apply heat. Rather, we want to apply ice bag to alleviate pain in our patients. We also want to observe for signs and symptoms of peritonitis. Remember, we talked about peritonitis earlier, where we said itis was inflammation, perito means peritoneum. So again, when you're observing for signs and symptoms of peritonitis, what would you see in your patient that will cause you to suspect the patient might be having peritonitis, which is a complication of appendicitis? So you can see, remember we talked of rebound tenderness, where we said when you press down on the abdomen, they don't usually complain of pain, but if you take out your hands, they have this severe pain when you remove your hand. That's what we refer to as rebound tenderness. Again, if there's complications after surgery for our clients with appendicitis, they would always put in a gastrointestinal tube. So you must always remember that for the NCLEX, whenever your patient has an NG tube in place and he begins to complain of nausea, the first thing you want to do is to check that the NG tube is functioning correctly, because the client's nausea may be related to a blockage of the NG tube. So again, you want to take note of that for the NCLEX. Again, if your patient has an NG tube in place, begins to complain of feeling nauseous, you want to at least check that our NG tube is not blocked. We might also carry out surgical removal of the appendix, and that will be what we refer to as appendectomy. Again, ectomy. Ectomy, what does that tell me? ectomy is a suffix for cutting out, like surgically removing something. So again, when I see ectomy, whatever is the big word in front of it, I know that something is being taken out, or probably the organ before the ectomy is being taken out. So we might need to carry out surgical removal of the appendix. Part of our normal post-op care would be to place the patient on antibiotic, pain management, surgical wound management. We might also need to keep him in Fowler's position. Again, on the NCLEX, positioning is very key. Positioning is very key because for this particular patient who's had abdominal surgery, when we put him in Fowler's position, it's going to help to relieve that abdominal pain, and it's also going to help to ease the patient's breathing. One other thing you need to watch out for with clients with appendix, all of a sudden they tell you, I'm feeling better, I don't feel the pain again. You need to watch out for sudden cessation of pain because that could tell us it's possibly been a perforation and that's an emergency. So again, with appendicitis, you want to watch out for sudden cessation of pain, and that will tell you you probably have an emergency on your hands. Okay, so we already talked about that. Sudden cessation of pain tells you there's a possible emergency there. With gastritis, again, that's my itis there, inflammation. Gastro tells me stomach. So I know this would be an inflammation of the lining of the stomach. What could cause this? Infection could cause gastritis. Injury, regular use of pain pills, especially your NSAIDs. So again, when I see NSAIDs, my patient is on NSAIDs, you want to think about gastritis. So you must be able to relate all of this together, put 1 and 2 together. Again, too much alcohol, that could also cause gastritis. When we assess our patient with gastritis, what are they going to tell us? What are we going to see? They will tell you they have this uncomfortable feeling in their abdomen. They will tell you they're having headaches, those GIT symptoms, anorexia, nausea, vomit that could possibly contain blood. And as part of our plan for gastritis, we want to keep this patient neoperoral and progress to a bland diet. We might need to give antacids to relieve the pain, and we'll need to refer them to an appropriate agency, especially if alcohol abuse has been verified in this patient. So that's just a quick synopsis of what we need to know for gastritis as related to the NCLEX. So again, think about NSAIDs, think about alcoholism. So when the patient presents with a history of severe alcoholism and then is beginning to complain of GIT symptoms, you want to start thinking of possible gastritis in this patient. The next I would like us to look at would be pyloric stenosis. Again, we want to go back to our anatomy. Think about what the lower portion of the stomach that connects to the intestine, what is this called? That's called the pylorus. Again, break down these words. Stenosis. Steno, what does steno mean? It's a prefix for narrowing. So I know pyloric refers to the pyloric muscle here. Steno tells me about the narrowing. Something is getting narrowed. And osis refers to or is indicating a condition, maybe or not, whether a normal condition or a diseased condition, or sometimes an increase. So when I see pyloric stenosis, that tells me there is a condition of narrowing in the pylorus. So that's one way you can break down your disease conditions to understand what your topic is about. So with pyloric stenosis, this is a condition in which the opening between the stomach and the small intestines thicken. Again, it's thickening and it's going to lead to narrowing in that area. And this is actually a problem that affects babies between birth and 6 months of age. So like we already mentioned, in this condition, what are you going to see? The pylorus muscle is going to be blocking food from entering into the small intestines. So that's what you're going to see in this patient. So you can see this is what we refer to as pyloric stenosis. The muscles have thickened, they've narrowed the pathway, and then food is finding it difficult to go into the intestines. Okay, so again, you would always see what we refer to as non-biliary projectile vomiting in patients with pyloric stenosis, especially in infants or, well, in infants actually. So you always want to look out for projectile, non-bile or non-bilious stained vomiting. So that's one obvious symptom you will see in this client. They will have this forceful non-bilious vomiting, and that can lead to dehydration, can lead to weight loss in our patients. And again, because they keep vomiting, they are always hungry. These babies are always hungry. So you're looking, that's also what you'll be looking out for. You can also see visible peristalsis on the abdomen. You can also see a lump in the abdomen on the left side. So again, let's break down what we'll see in this client. So we said you would notice visible peristalsis waves in the abdomen. So because of that obstruction, the intestines, the stomach, the GIT tract is trying to move food as it should, but it's meeting that resistance. So that's why you're going to see, if you look at the stomach, you're going to see those wave forms, which we refer to as peristaltic waves. Again, we mentioned this non-bilious vomiting. It's usually projectile, coming up with force, especially in infants. Again, we said you will see a lump or a palpable olive-shaped tumor. So you're going to see a lump. We talked about this earlier. You're going to see a lump or palpable olive-shaped tumor in the epigastrium, especially with infants. Again, they would also have this epigastric fullness. They'll be very, very irritable. And we mentioned it that they are always hungry. They are always hungry, and they fail to gain weight because of this disease condition or the pyloric stenosis that the infant is suffering from. So again, because of that continuous vomiting, if they've been vomiting for maybe upwards of a week, it can result to metabolic alkalosis. And how are you going to know that this patient is in metabolic alkalosis? You're going to see an increase in both the serum pH and the serum bicarbonate. We'll talk about our arterial blood gas in subsequent classes. But again, when I see vomiting in my patients, I'm suspecting dehydration. I'm suspecting metabolic alkalosis. Remember, the HCl, well, let me leave that for now, but we'll talk about it subsequently so that we don't deviate. So what's our plan for this patient? What's our plan for this patient? We can carry out surgical intervention, one of which would be pylomyotomy. Again, just like I mentioned, you want to break down words on the NCLEX. That will tell you what you are dealing with. Look at that suffix there, otomy. Otomy, what does it refer to? The act of cutting or making an incision. Again, pyloro tells me the pylorus. Myo tells me muscles. So we are actually cutting into the circular muscles of the pylorus. That's how we want to break down words on the NCLEX. VAC tells me the vagus nerve. Otomy, again, we already talked about it, tells me about incision through cutting or making an incision. So when I see vagotomy, that tells me they are cutting into the vagus nerve. Anthrectomy. Antre is the anterior portion of the stomach. So we are going to take out ectomy, telling me we are cutting out. So ectomy, so that will be removal of the gastrin secreting portion of the stomach, and vagotomy there tells me we are severing the vagus nerve. Again, we can also carry out vagotomy and pyloroplasty. Again, break down the words. Don't be scared of these big words. What does plastic tells me? Plastic tells me plastic, repair, surgical repair. When I see pyloro, that tells me we are surgically repairing the pylorus. That's how you want to break down these words, especially if you see them on the NCLEX. So again, our plan with our client with pyloric stenosis would be, at least we need to prevent regurgitation and that persistent vomiting. So you want to educate the mother. Tell her you need to feed the baby in an upright position. Always hold the baby in a sitting position for 30 minutes after feeding. If possible, we want to give smaller, more frequent feedings. Remember I said on the NCLEX, small frequent feedings is always a good option on the NCLEX. Teach the mother to take time to burp the baby, to burp her baby. And again, once they put the baby to bed after feeding, you want to position the baby on the right side, because this positioning, again, remember I talked about positioning. You will see a lot of positioning questions on the NCLEX, and you always want to understand how that would help. So in School of Nursing or when we are going through the university, we are taught that this position is for this, use this position for this. But no, critical thinking must come in. You are not just putting him in that position. You always want to ask yourself, what do I intend to achieve when I put him in this position? So yes, I know that they said if the patient is unconscious, put him on left side lying. There might be something on that question that might negate that what you already know, what you've already memorized. Remember we said the NCLEX is a critical thinking exam. So you're not just going to vomit everything you've read. You always want to carry out application and analysis. So again, when we position this client side lying, it will prevent aspiration of vomitus. Even the right side aids the stomach emptying through the pyloric valve by gravity. So that's why we want to place him on the right side. Again, preoperatively, we can give IV fluids, check the client's skin turgor, fontanelles, urinary output. Again, remember with the elderly, you want to check skin turgor on the sternum. So take that note, write down that for the NCLEX. You want to check for skin turgor on the sternum. So again, you're going to pull the skin, use 2 fingers to gently grab the skin, and then look out how long it takes for the skin to return back. If it's more than 2 seconds, we are becoming suspicious. So you want to take note of that. And please don't spend time taking pictures of the screen. The videos will be uploaded, so you can still take time to go back and review the videos. So you want to spend your time listening and concentrating. Okay, so like I said, we want to measure vomitus. Remember we said there's going to be that non-bilious projectile vomiting. Why are we measuring this vomitus? Because that can also give us an idea of the client's hydration status. So if he has vomited so much, we can look at it and say, wow, this child possibly might be dehydrated. So you want to measure vomitus. We want to correct any fluid and electrolyte abnormalities. We want to monitor for complications. So again, remember we talked about how vomiting can affect the electrolyte balance. So we're looking out for hypokalemia, we're looking out for dehydration, are there signs of shock? And you also want to support the parents who have this infant that has developed this disease condition. So you want to allow for verbalization of the parents' concern, the anxieties. You also want to instruct the parents on the expected progress and expected behaviors that they would see in this child. After the procedures or the surgical interventions, we'll need to manage him post-operatively. You want to keep the incision site clean and dry. We want to provide parenteral fluids at the ordered rate. We want to monitor the patient's warmth. Again, small frequent feedings of glucose water or electrolytes, 4 to 6 hours post-operatively. And if those clear fluids are retained, we can start formula feeding 24 hours post-operatively. Very important, you want to teach the parents to fold the diaper so that it doesn't touch the incision site. So again, you want to teach the parents to fold the diaper so that it doesn't touch the incision site. Let's quickly look at cholecystitis. Again, break it down. We're going to be doing a lot of breaking down. Chole, what does chole tell me? Relates to bile. It relates to bile pigments. It relates to bile ducts. How about this cyst over here? Okay, so let me get my pointer. Okay, so cyst. What does cyst tell me? Cyst is a prefix denoting a bladder, a kind of bladder. So when I see cyst, that tells me bladder and our common itis, which is inflammation. So again, we still have the same chole, which is our bile or bile pigments or bile ducts. Lithiasis, what is lithiasis? That's a stone. That refers to stone. So when I see cholecystitis, it's simple. Inflammation of the bile bladder. But again, we don't call it bile bladder, so we just call it gall bladder. But by breaking it down, you can know what you're dealing with. So that's cholecystitis, inflammation of the gall bladder. And it's actually caused by stones that block the tube leading from the gallbladder to the small intestine. So you can see that stone right there causing the obstruction and causing this patient to have cholecystitis. Again, you can also, we also have cholelithiasis, which is the presence of stones in the gallbladder. So that's our gallbladder right there. And those are stones. So you can see, so this patient will present with cholecystitis when you have stones obstructing the tube that leads from the gallbladder to the small intestines. And when you have stones in the gallbladder itself, that will refer to as cholelithiasis. Okay, so when the patient presents with any of this, what are their complaints? What are they going to be telling us? They will tell us they have this intolerance to fatty foods. So that's one obvious sign you would notice in patients with either of these conditions. They will have this intolerance to fatty food. They will complain of GIT symptoms like our dyspepsia or your indigestion, or nausea, vomiting, flatulence, eructation or belching. They would also complain of severe pain in the upper right quadrant of the abdomen that radiates to the back and the right shoulder. So again, you want to know your abdominal quadrant so that when your patient gives you or tells you where he's feeling a pain, you want to know the organ that is in that quadrant, and you want to relate that to the patient's presentation. So when I see when the NCLEX tells me the patient comes in complaining of severe pain in the upper right quadrant of the abdomen that radiates to the back and right shoulders, I'm suspecting could it be cholecystitis or cholelithiasis. So that would be biliary pain. So that's what they refer to as biliary pain. When they tell you they have severe pain in the upper right quadrant that radiates to the back and the right shoulders. Again, because of that inflammation, we are going to see elevated temperature, they will be sweaty, and we would always see dark urine. So there will be dark urine and clay-colored stools. So they will complain of their urine being dark-colored, and they will have these clay-colored stools. What's our plan for these clients? Again, rest is very vital, especially if they present in an acute state. We want to give them IV fluid. Remember, we said they will have fever. And once I see fever, I always think about dehydration. So I want to give them IV fluid. We already said they will be sweaty. So we want to place them on IV fluid. We might need to suction our patients. We will need to give them analgesics. Remember, we talked about that biliary pain, that lower right quadrant pain that radiates to the back and the right. And it's usually accompanied by nausea and vomiting. So that's why we want to place them on analgesia. We want to give them antibiotics. We want to give them low-fat liquids like powdered supplements that are high in protein, carbohydrates that are stirred into skim milk. We want them to avoid fried foods, pork, cheese, alcohol. And we might need to carry out laparoscopic cholecystectomy or our traditional cholecystectomy. Again, ectomy tells me they are taking off something. Chole there tells me bile. Cyst tell me bladder. So I know the gallbladder is going out. So when I see this word, I want to break it down. And again, laparoscopy. So that would be using a laparoscope to take out the gallbladder in this patient. So like I mentioned, you always want to break down these words and understand what it's telling you. So again, you're going to use the laparoscope to visualize the internal organs and dissect or cut out the gallbladder. Again, for these clients, we might need to keep them nil per oral on the day before the outpatient procedure, because this would be an outpatient procedure, probably in the office or in a surgical center. So we'll need to keep them nil per oral. And post-operatively, you want to monitor for bleeding, which is a possible complication that can arise. And with the traditional cholecystectomy, this would be removal of the gallbladder through an incision. Again, with our post-operative care, we need to place them on nutritional supplements of glucose and protein hydrolysates. We'll need to put an NG tube before surgery. And post-operatively, we'll need to medicate them for pain. There might be need to put a T-tube. So we'll need to monitor our T-tube. So that's your T-tube there that's placed in our patient. So that's our T-tube there. That's our bowel drainage bag. And the T-tube is placed in the common bowel duct. So why do we need this T-tube? It's usually inserted to ensure drainage of bile from the common bile duct until the edema in this area has gone down. So that's why we put in a T-tube to help to drain bile from the common bile duct. Very important with your T-tube is to ensure that our drainage bag is always below the level of the gallbladder. So you want to make sure the drainage bag is below the level of the gallbladder. Look at how this patient is positioned. Like I mentioned earlier, positioning is very key on the NCLEX. So we want to maintain him in a semifowler's position. Again, we want to observe for jaundice. What are the signs you would see that will tell you this patient might be having jaundice? Look at the eyes, look at the sclera. Is it yellow? Look at the stool. The stool is supposed to slowly progress from light to dark color after we remove our T-tube. If it doesn't, then our patient is possibly having jaundice. We might also need to place him on low fat, high carbohydrates, and high protein diets. Let's quickly look at Crohn's disease versus ulcerative colitis. Again, with Crohn's disease, that would be inflammatory condition of any area of the large or small intestine, usually the ileum and the ascending colon, while ulcerative colitis refers to inflammatory condition of the colon that is characterized by eroded areas of the mucous membrane and tissues beneath it. So you can see how this is happening in different segments, while this is continuous in just one particular area. So that's one obvious difference you might see. So with Crohn's disease, the inflammation happens in a non-continuous segment, but with colitis, ulcerative colitis, it's in a continuous segment of the intestines. So let's compare both of them and just look at the key features. So one thing we're going to notice with Crohn's disease, there's usually fat in our stool or in the patient's stool. So with Crohn's disease, there's fatty, you would look at the stool and it always contains fat, but that would be absent in ulcerative colitis. With malignancy, there's a very high chance that ulcerative colitis can progress to becoming malignant. Again, if you look at bleeding, bleeding is actually common with ulcerative colitis. So again, it's common. You could see blood, we can see pus, we can see mucus in the stool. One other important thing we want to look at would be, when does this patient complain of pain? With Crohn's disease, they usually complain of pain after meals, whereas with ulcerative colitis, they will complain of pain before they use the toilet. And finally, with diarrhea, with ulcerative colitis, you would see upwards of 10 to 20 liquid stools per day, and it's often bloody. Again, with this loss of fluid, loss of electrolytes in the stool, in the diarrhea, you want to start suspecting hypokalemia in your patient. Again, with hypokalemia, you want to think about how it affects the heart. Remember potassium and the electrolyte conduction system of the heart. We won't go into that, but again, you just want to take note of that. So what's our plan for this client? We want to place them on a high protein, high calorie, low fat and fiber diet. We want to maintain fluid, maintain electrolyte balance. We want to provide parenteral nutrition if we need to rest the bowels. We want to provide medications like our analgesics for the pain. We want to provide anticholinergics. We want to place them on antibiotics. We want to place them on corticosteroids to help to reduce the inflammatory process. We want to place them on immune modulators. For example, our azathioprine. So that's one example of your immune modulators. What are your immune modulators? What do? They help to stimulate or suppress the immune system, which helps the body to fight infections or other disease processes. So your azathioprine would help to suppress the immune response Again, you want to take note of the fact that your immune modulators can cause, when they suppress the immune response, what happens? The body is open to any infection. So when they suppress your immune response, they can cause bone marrow suppression. So again, when I see my patient on the NCLEX is on an immune modulator or something that can depress his immune system, I'm already thinking bone marrow suppression. I'm already thinking increased risk for infection. Again, we might need to place them on salicylate-containing compounds like our sulfasalazine. So again, this is a salicylate compound. It's an anti-inflammatory drug. I'm referring to the sulfasalazine, and it's used to treat Crohn's disease, ulcerative colitis. We even use it for rheumatoid arthritis. Again, we might need to carry out ileostomy on our patient. Again, stomy is there, ileum. So when you break it down, you know that ostomy will tell me we are surgically making an opening. So we are making an opening surgically into the ileum. So that will be your ileostomy. So again, we want to carry out this procedure on this patient with Crohn's disease or ulcerative colitis. Let's quickly look at intestinal obstruction. Just as the name sounds, it's just obstruction of the intestines, which prevents the normal movements of the products of digestion, either in the small bowel or the large bowel. It could either be that the normal flow through the intestines is interrupted, maybe mechanically, so where you have mechanical obstruction, it could be as a result of maybe liquid stool or gas, or even a hernia or a tumor. It could even be from adhesions or strictures, or even a volvulus. Any of these would be a mechanical obstruction. It can also be as a result of a functional obstruction, which would disrupt the peristalsis. So again, the peristalsis would be that waves of contractions that run through the digestive tract. So again, if we have a functional obstruction, it would be that the patient possibly has paralytic ileus, which would be paralysis of the intestine. So paralytic ileus occurs when the muscle contractions that move food through the intestines are temporarily paralyzed. So there's no physical obstruction. It's just that the muscles have become paralyzed, maybe as a result of nerve dysfunctions and all of that. So what do we assess? What do we see in this patient? How will this patient present? They can present with nausea and vomiting. Again, they will have these high-pitched sounds, and then they have these decreased or absent bowel sounds below the area of obstruction. So again, if we have the obstruction maybe somewhere around here, if you listen to bowel sounds above the area of the obstructions, there will be high-pitched bowel sounds, whereas below the area of obstructions, the bowel sounds will be decreased or they will be totally absent. The client would also present with abdominal pain and abdominal distension. They could also present with obstipation, which would be absence of stool or gas, and that would be as a result of a complete obstruction. What's our plan for this client? We need to quickly carry out intestinal decompression, where we're going to insert a tube into the stomach or the intestine through the nose or the mouth to allow fluid or air to be removed or whatever is causing the obstruction or the abdominal distension. Tubes we could use would include our Salem sump or our Levin tubes. So those would be your nasogastric tubes. Or we can use either of our intestinal tubes like your Miller-Abbott tube or your Cantor tube. We'll need to place this client on nil per oral. Fluid and electrolyte replacement. We need to monitor intake and output and electrolyte levels. We'll need to assist with activities of daily living. We want to provide good oral and skin care. Again, positioning, very important on the NCLEX. So we want to place this client on Fowler's positioning, a position to facilitate breathing. And again, surgery can be done to relieve the obstruction. So what are the types of surgeries we can do for this client? We can carry out exploratory laparotomy, especially for like possible adhesion removal. We can carry out resection and anastomosis. Here, we are cutting in, taking out the bad portion or the deadened portion or the diseased portion of the bowel, and we are joining the remaining ends together. That's what they mean by anastomosis. Again, we can carry out an abdominal perineal resection. We can also carry out intestinal ostomies. Again, during ostomy surgery of the bowel, they're going to try to connect the large or small intestine to the skin on the outside of the abdomen. So now let's review intestinal ostomies for fecal diversion. So again, we said ostomy is opening into the colon to allow passage of intestinal contents. So again, ostomy is opening into the colon to allow passage of intestinal content. And again, a stoma is an opening on the abdomen where the intestine is sutured to the skin surface. So that would be a stoma there. So we have, we create an opening where the intestine is sutured to the skin surface. Most times we can do this for cancer of the colon or diverticulitis or intestinal obstruction. And these are common types of ostomies. It could be a colostomy, which is a surgically created opening into the colon, which is the large intestine, through the abdomen. Again, the purpose is to allow us to bypass that damaged part of the colon. And if a client has colostomy, usually the output from the colostomy could be liquid, or it could be a formed stool, or somewhere in between. It could be gas. There could also be odor coming from the appliance. So again, that would be your colostomy. We could also have an ileostomy, and we could also have a urostomy. So these are different types of ostomies that our patient could have. Let's look at our plan for a client who is planned to have an ostomy. So part of our preoperative care would be that psychological support. You can look at this and see how it's going to be inconvenient or uncomfortable for this patient. So you want to start thinking about providing psychological support and explanation, teaching and guidance for this patient. We want to place them on a high calorie, high protein, high carbohydrate, low residue diet at least a week before. And then we'll need to place them nil per oral after midnight on the day of the planned surgery. We'll want to place tube prior to surgery, maybe a nasogastric tube or an intestinal tube. We want to assist this client because the client may be weakened. He may be weak from extensive preparation procedures. We want to give laxatives or enemas the evening before and the morning of surgery. We can also have an enterostomal healthcare provider see this client. So this is a health professional that is trained in the care of patients with a stoma or colostomy. We'll need to place them on antibiotics at least a day before surgery. We want to monitor for fluid and electrolyte imbalances. And again, we might need to refer them to the enterostomal therapist and United Ostomy Association. So they support people that have this kind of procedures and help to distribute supplies to their members so that they can better take care of themselves. So post-operatively, we want to have our NG tube, our intestinal decompression in place until peristalsis returns. We want to maintain nil per oral. We'll need to give him clear liquids and progress to solid, low residue diet. We want to monitor intake and output and fluid and electrolyte balance. We want to observe and record the condition of the stoma. Okay, so in the first few days, this is what the stoma is supposed to look like. So the first few days, we expect it to appear beefy red and swollen. So in the first few days, it should appear beefy red and swollen. Gradually, the swelling should recede and the color becomes pink or red. So on the NCLEX, you must notify the healthcare provider if the stoma becomes dark blue or blackish or purple. What does that tell you? It tells you there's, or it indicates that there's insufficient blood supply to the stoma. So again, you want to take note of that within the first few days, it appears beefy red and swollen, and gradually the swelling recedes and the color becomes pink or red. And then if you notice it's turning blue or purple or blackish, you want to immediately notify the healthcare provider because that indicates that the stoma is getting insufficient blood supply. We also want to observe and record description of any drainage from the stomach. Again, you must know what the right drainage should be, because usually for the first 1 to 2 days, usually all we'll see would be mucus coming from the stomach. So again, that would be expected. If the NCLEX tells you a patient had an ostomy 2 days ago, on the second day, only mucus is coming out, that is expected if we see mucus within the first 2 days. And again, the ostoma would begin to function 3 to 6 days post-operatively. Key words you need to take note of. So from the 3rd day to the 6th day, we expect the stomach to start functioning as it should. We also want to promote positive adjustment to the ostomy. So encourage the client to look at the stomach. Let them get used to it. Encourage early participation in ostomy care. Reinforce positive aspects of the colostomy. All of this just to promote that positive adjustment to this new situation that they found themselves. With skin care, remember that the effects of the skin depends on the consistency of the drainage from the stomach, the medications the patient is on, the frequency and removal of appliance and the adhesive. So again, you must know that the pouch opening must be 1/8 inch larger than the stomach itself. So the pouch opening must be 1/8 inch larger than the stomach. Again, because of high concentration of the digestive enzymes, the drainage is usually irritating, especially if it's an ileostomy. It's usually irritating to the skin, and it can cause excoriation and ulceration. So we must use some form of protection or skin barrier to keep that drainage from contacting the skin. So again, a skin barrier does not decrease odor from the appliance. Odor is actually controlled by the diet that the patient eats. So we want to use skin barrier to protect the skin surrounding the stomach. Again, when we cleanse the skin, you don't want to rub. We want to clean the skin gently and pat it dry. So you want to pat it dry. Do not rub, because that would cause further excoriation. And once the pouch is applied, we apply it by pressing the adhesive area to the skin for at least 30 seconds so that it adheres very well. Again, you must take note of this, that you want to change the appliance whenever the seal breaks or when it is 1/3 or 1/4 full. So that's when we want to change the appliance. Whenever the seal breaks or when it's 1/3 or 1/4 full. Again, with this appliance, if there's absence of drainage from the ileostomy for 6 hours or more, that's a red flag. The patient tells you that the last time there was drainage was 12 o'clock, and this is like 7 p.m. Once there's absence of drainage from the ileostomy for 6 hours or more, that's a red flag. Or if there's any sudden decrease in drainage, that's a red flag. Or if there's onset of severe abdominal pain, that's a red flag. So if we notice any of this, you must report it to the healthcare provider immediately, because it could mean that there's an obstruction, something is obstructing our drainage. So like I said, absence of drainage, any sudden decrease in drainage, any sudden or onset of severe abdominal pain, you must report that to the healthcare provider. Again, with colostomy irrigation, especially for sigmoid colostomy, the purpose is actually to stimulate emptying of the colon of gas, mucus, feces at scheduled times to avoid need for appliance. So in this procedure, we want to start it from at least 5 to 7 days post-operatively, and when possible, the client should be sitting on the toilet for the procedure. So the client should be sitting on the toilet for the procedure. It should be performed after a meal, same time each day. We want to use between 500 to 1,500 mils of lukewarm water and use a special irrigating sleeve and cone. We want to insert the catheter 8 cm or 3 inches. We want to hang the irrigating container at shoulder height. So that's our irrigating solution there. We want to hang it at shoulder height, maybe between 18 to 20 inches. And then you want to clamp the tubing So when we have this running in, if all of a sudden the patient complains of cramping, then we need to clamp the tubing and allow the patient to rest before we resume the procedure again. So again, if the patient complains of cramping pains, you want to clamp the tubing, allow the patient to rest before you resume again, allow the water to flow in over 5 to 10 minutes. And then we're going to allow 10 to 15 minutes to allow the drainage to come out. We want to leave the sleeve in place when the client moves around for at least 30 to 45 minutes, and then we want to clean with soap and water and pat dry. This will be what we refer to as a cork pouch. So this is a cork pouch, or it can also be called a continent ileostomy. So with this, you are able to retain the waste within the body until the patient decides to remove it. That's why it's referred to as a continent ileostomy, because there's no leakage. You are the one who decides when you want to drain it. So with care of the continent ileo reservoir, or our cork pouch, our continent ileostomy, post-operatively, after it has been set up through surgery, post-operatively, a catheter is inserted and attached to a drainage bag. We want to instill every 3 hours, 10 to 20 mils normal saline into the pouch, and then we want to drain by gravity, and this will be kept in place for 2 weeks. So subsequently, anytime we want to drain, we'll just lubricate the catheter, insert it 5 cm or 2 inches, and then we drain into the toilet, after which we can wash and dry the stomach. This is what we refer to as a cork pouch. Again, if you feel resistance when you are doing any of this, we can inject 20 mils of air or 20 mils of water using a syringe through the catheter, and that would help to open up the pathway. With esophageal atresia, again, atresia tells me opening. A, we said yesterday, was a prefix for absent. So it tells me there's an absent opening where? On the esophagus. So esophageal atresia refers to an absent opening on the esophagus. How about tracheoesophageal fistula? So trachea tells me trachea, esophageal tells me esophagus, and fistula tells me there's an abnormal connection. So there's a connection there. So that would be your tracheoesophageal fistula. There's a connection between the tracheal and the esophagus, an abnormal connection between the trachea and the esophagus. Again, what would we see in a patient or an infant with tracheoesophageal fistula? There would be drooling. They will have this excessive saliva because now there's this obstruction and all of the fluid, the saliva is building up in their mouth. So they will have that excessive drooling. Because air is going into the stomach, you're going to have that abdominal distension. They would have cyanosis. Our plan would be to carry out surgical repair. Preoperatively, we want to position the client supine or prone with the head of the bed elevated at least 30 degrees. We want to give IV fluids and antibiotics. Again, you want to maintain a patent airway. Post-operatively, we want to care for the incision site. So observe the incision site, especially for inflammation. We want to prevent pulmonary complications. So you can suction the patient, position him. So that will help to prevent any pulmonary complications. We want to give IV fluids and antibiotics. We want to place this client on parenteral nutrition until gastrostomy or oral feedings can be tolerated. Again, prefix, ostomy, opening, gastro, stomach. I know that would be an opening into the stomach where we can feed these patients. So that's what your gastrostomy would mean. Let's quickly look at systemic lupus erythematosus, or our SLE. So this would be an inflammatory disease that is caused when the immune system attacks its own tissue. Again, lupus can affect the joints. It's a multi-system organ dysfunction because it affects every body system. It affects the joints, It affects the skin, it affects the kidneys, it affects the blood cells, the heart, the lungs. So like we mentioned on the screen, it's a chronic systemic inflammatory disease of connective tissue that involves the skin, the joints, the serous membranes, the kidneys, the hematologic system, the CNS. Diagnosis tests would include testing for rheumatoid factors. So let's break down all of these organ affectations with SLE. Let's look at musculoskeletal problems. What are you going to see? We're going to see polyarthralgia, we'll see arthritis, we'll see joint swelling, we'll see polymyositis. Again, break it down. Poly, what does poly tell me? Many, multiple, many. Atra, what does atra tells me? It tells me joint. That's a prefix for joint. Algia, what does algia tell me? Pain. So I don't need someone to tell me that polyarthralgia would mean multiple joint pain. Arthritis, atra again tells me joint. Itis tells me inflammation. So I know this would be inflammation of the joint. And then when there's obvious inflammation, we are obviously going to see joint swelling. Poly tells me many. Myo tells me muscles. Itis tells me inflammation. Always break down this word so that you can have a good insight of what the question is about. So again, polymyositis would be multiple inflammations of the muscles. Okay, so that would be what you will see with musculoskeletal problems. We could also see dermatological problems. Again, you want to take note of this. On the NCLEX, when I see butterfly rash, you can see how this rash kinds of forms a butterfly here. So you can see how this rash kinds of forms a butterfly. That's your giveaway that your patient has systemic lupus erythematosus. So again, you're going to see that butterfly rash that spreads across the bridge of the nose and the cheeks. That's a giveaway there for your SLE. The client could also have papular rash, erythematosus, purpuric lesions. They could complain of oral ulcers, alopecia. So those are some dermatological problems you would see in this patient. Again, you could also have cardiopulmonary problems like our pericarditis. You can see pleural effusion, pericardium. That tells me heart. Itis, inflammation. That's inflammation of the pericardium. That thin sac-like membrane around the heart. So again, it gets inflamed. How are you going to know your patient has pericarditis? One of the most common symptom you would see is that they're going to complain of that sharp stabbing pain that travels to the left shoulder and the neck. So they're going to complain of a sharp stabbing chest pain. They could also complain of shortness of breath, palpitation, even extremities, swelling in the extremities. That's how you know your patient has pericarditis. You can also see pleural effusion. So there will be buildup of fluid between the layers of the tissue that line the lungs and the chest cavity. With that fluid building up, they will be coughing. They will tell you they have chest pain. They would also complain of shortness of breath. So again, the NCLEX might not tell you this patient has SLE, but it will tell you the patient presented with a butterfly kind of rash and with complaints of stabbing chest pain, the shortness of breath and all of that. So you want to always identify these symptoms when you see them. Again, renal problems would include urea. Urea means in the urine. So we're going to see blood in the urine. We're going to see protein in their urine. And this can subsequently result to renal failure in this patient. We could also see CNS problems like changes in behavior, even psychosis. You can see psychosis. Remember, when your client is having psychosis, their thoughts and perceptions is disrupted. They may have difficulty recognizing what is real and what is not. So you're going to see that in these clients. We can also see vascular and lymphatic problems. So we could see papular erythematosus and purpuric lesions on the fingertips, on the toes, their forearms, and their hands. We can also see lymph adenopathy. So this would be abnormal. The lymph nodes become abnormal in sizes or in their consistency or in their numbers. So that would be lymphadenopathy. You would also see Raynaud's phenomenon. With Raynaud's phenomenon, if you look at the digits of their hands, especially if they're exposed to cold, if the person is exposed to cold, the digits in their hands, they start complaining of pain in their fingertips, or the color starts changing. That's what we refer to as Raynaud's phenomenon. You can also see this with clients with systemic lupus erythematosus. So again, that's your pleural effusion there. When we see fluid building up within the pleural space, we also said they could have heart problems, where we talked about pericarditis. We said it could also affect the kidneys or renal problems, where we'll see hematuria, proteinuria. We also said there will be musculoskeletal problems, your polyarthritis or myalgia and all of that. And we talked about the butterfly rash and our Raynaud's phenomenon. Again, with Raynaud's phenomenon, once they're exposed to cold, they start complaining of pain in their fingers, the digits start changing color. That's your Raynaud's phenomenon. What's our plan for clients with systemic lupus erythematosus? You want to monitor for increase in severity of the illness, maybe breakout fever. We want to relieve pain and discomfort. We want to give them NSAIDs. We want to give them acetaminophen. Again, hydrochloroquine is very, very effective in these clients. For us here, we know it as an anti-malarial, but again, you can also use it to manage these patients because it helps to relieve pain, it helps to relieve that swelling and joint stiffness, and even the rash on their face. We also want to protect them from ultraviolet rays and sunlight because they have this photosensitivity, they have this scaly and itching rash, so you want to protect them from the sun. We want to give them corticosteroids, especially if there's any exacerbation. So again, we want to place them on immunosuppressive medication. That's our friend there, azathioprine, which we said is an immune modulator. Again, remember, when we see some of these immunosuppressive medications on the NCLEX, you're already thinking about risks for infection because we said it depresses their immune system, it depresses the bone marrow, and that could put your client at risk for infection. Always think about that when you see your cyclophosphamide on the NCLEX or your azathioprine. We might also need to place them on gamma globulins. These ones play an important role in liver function, blood clotting, and even fighting infections. We might also need to carry out plasmapheresis, where we try to exchange the patient's blood plasma. So we take out the foreign bodies that may be triggering that immune response. And you also need to educate and support this client. And the last but not the least we'll look at today would be gastrointestinal ulcer, our stomach ulcer, or our duodenal ulcer. Remember, with gastric ulcers, these are sores that develop on the lining of the stomach. Duodenal ulcers would actually happen in the lining of the duodenum. What can cause your client to have a gastric ulcer or a duodenal ulcer? It could be as a result of excavation that is forming on the mucosal wall. Helicobacter pylori has always been implicated as a cause of a gastric ulcer. Again, it could also run in the family. So let's look at some risk factors. Let's compare duodenal ulcer with gastric ulcer. So what are the key features we are looking at here? Again, in age, you could see with chronic duodenal ulcer, the people at risk are between 30 to 60 years, while gastric ulcer can occur there's more with people 50 years and older. With sex, there's a ratio of 3:1 with duodenal ulcer, whereas with gastric ulcer, there's 1:1. So again, you can, when you watch the video, you can pause this and run through this. So I just want to run through this because of time. You can pause the video and run through that. Let's look at the plan. One major part of our plan for this client would be to have them eat 3 meals per day. Again, small, frequent feeding. You can imagine how many times we've mentioned small, frequent feedings on this course. We want to have them avoid extremes in temperature. Caffeine is not good for them. Alcohol is not good for them. Coffee is not good for them. They need to avoid this. They need to avoid milk and cream. They need to reduce stress. They need to stop smoking. And again, we might need to place them on medications like our antacid. Again, one example of your antacid would be our magnesium and aluminum hydroxide. This will need to administer 1 hour before or after meals. We might also need to give them our histamine receptor antagonists like your cimetidine or your ranitidine. They need to take it with food. This is going to help to reduce the amount of acid that is produced by the cells in the lining of the stomach. Another medication we can give would be our anticholinergics, like our propantheline. These ones will aid relaxation. We can also give them cytoprotective medications like our sucralfate. So you want to give the patient sucralfate 1 hour before meals. This agent, our sucralfate, is going to help to coat the ulcerated area. So that's what your sucralfate is going to do for help the patient. Another example of your cytoprotective medication would be your misoprostol. We can also use that. Again, we can use our proton pump inhibitors like our omeprazole. This is going to also reduce stomach acid production. Again, we can use any of these medications, or we can carry out surgical intervention, ectomy. So here we are taking out part of the stomach. So gastrectomy would be removal of the stomach and maybe attachment to the upper portion of the duodenum. We can carry out vagotomy, which would be cutting the vagus nerve, and this will help to decrease hydrochloric acid secretion in the stomach. We can carry out a Bilirot 1 operation, which would be partial removal of the stomach, and then we join it with the duodenum. So that would be a Bilirot 1, or we can carry out a Bilirot 2, which would be removal of the distal segment of the stomach, and then we're going to join it with the jejunum. So that's your Bilirot 2. And for these patients, they will need to be placed on vitamin B12 actually, vitamin B12. They will need to be placed on vitamin B12 for life because people who have had a partial or complete gastrectomy will need to supplement their diet with oral vitamin B12, even iron supplements. Again, you want to take note of that. Post-operatively, we want to provide gastric decompression to help to empty the contents of the stomach. Like we said, we can give them vitamin B12 through the parenteral route. Again, we said it's required for life if they've had a partial or complete gastrectomy. We would also need to encourage deep breathing, observe our nasogastric drainage. We would also observe for peristalsis, listen for bowel sounds, record passage of flatus or stool. We would also need to teach preventive measures for dumping syndrome. That's a complication that can arise with gastrectomy or any of these surgical interventions we just talked about. So what is dumping syndrome? Dumping syndrome is actually, or sometimes they call it rapid gastric emptying. It's actually a condition in which food moves too quickly from the stomach to the duodenum. So again, I'm going to fall back to this, and you can see that we connected the stomach directly to the duodenum. So we're going to have food moving rapidly from the stomach into the duodenum, and that could result to dumping syndrome. So that could result to dumping syndrome, we said. And again, it can occur 15 to 30 minutes after eating. So it can occur 15 to 30 minutes after eating, and then the patient is going to present. So you can see a truck just to give you a picture of the dumping syndrome. So the food is moving rapidly from the stomach to the duodenum. And we said it can occur 15 to 30 minutes after eating. So the patient has had this procedure, maybe a gastrectomy, and he just takes his meals, and then he begins to start complaining of weakness. He's feeling tired, or dizziness, or feeling lightheadedness, or he tells you everywhere is spinning, and he's sweating. You can see how this patient is sweating. You want to start suspecting dumping syndrome on the NCLEX. They could also have tachycardia. If you check their blood pressure, they could be hypotensive. They could complain of abdominal cramping or diarrhea, even nausea. Again, think about it. They possibly have been a rapid passage of food from the stomach into the duodenum, or there's been rapid gastric emptying, and your patient is suffering from a dumping syndrome. So again, how are we going to manage this with these patients? First of all, we want to restrict fluids with meals. So you want to teach the patient, when you are eating, restrict your fluids. You can drink 1 hour before or 1 hour after. So you don't want them eating and drinking at the same time because of that risk of dumping syndrome. Again, teach them to eat in a semi-recumbent position. You elevate the head of the bed at least 30 degrees to 45 degrees. So you want to teach them to eat in a semi-recumbent position. You want to have them lie down 20 to 30 minutes after eating. This is very key with dumping syndrome. Have them lie down 20 to 30 minutes after eating. Again, that's our friend there. Eat small, frequent meals. You want to have them eat small, frequent meals. And again, we want to give them complex carbohydrates. You want them to avoid simple sugars. And again, we can give them antispasmodics like our Buscopan, just to aid with any of those abdominal cramps that they might complain of. At this point, we've come to the end of the course. If you haven't taken the quiz, or if you did, you can see that as a pre-test. I would like you to go back and take the quiz and see how you improve on the test. I also like to just give just 5 minutes. If you have any questions, we can take them now. So you can unmute yourself, and if you have any questions, we can take them. Thank you very much.